Welcome back to the Deep Dive. Today we're tackling something incredibly common, often really debilitating. Nerve pain shooting down the leg. We're digging into lumbosacral radiculopathy, that's sciatica, and also lumbar spinal stenosis, LSS.
Yeah, they sound technical, but lots of people experience them. Essentially, a nerve root in your lower back gets pinched or compressed,
Right.
and that causes that pain or numbness, sometimes burning, tingling, usually running down the leg along the nerve path. For sciatica specifically, we're talking the sciatic nerve, L4 down to S3.
And it's often one-sided.
Usually,
Yeah.
yeah. And about 90% of the time, the culprit is a lumbar disc herniation pressing on that nerve root.
Okay, so discs for acute sciatica, maybe more degenerative stuff for LSS. But our mission today is really drilling down on the non-surgical side. How well does it work?
Exactly. We want to look at, the quick fixes people might reach for, like injections, versus the long-term strategies like exercise.
And figure out where each fits in and when maybe surgery is the right call.
And here's maybe the most surprising thing up front. Most acute sciatica actually gets better by itself with conservative care. And even when you compare very different treatments.
Like surgery versus physical therapy.
Right. If you look out a year or two, the functional outcomes, how well people are doing, often end up looking remarkably similar. Time plays a huge role here.
That's a really important perspective to start with. So if time and the body's own healing are key, let's talk basics. What's the typical timeline? How often does conservative care actually work?
So for a typical acute sciatica flare-up, you'd expect symptoms to start improving within, say, 4 to 6 weeks.
Okay.
And the success rate for conservative management, meaning everything but surgery, is actually really high, somewhere in the range of 80 to 90%.
Wow, 80 to 90%. That's huge. But when you're in agony, the first instinct is just stop moving, right? Lie down. Is bed rest the answer?
Yeah, that's the instinct, but it's generally the wrong one. Maybe 1 or 2 days of rest right at the beginning just to calm things down.
But not more.
Definitely not more. Prolonged bed rest, anything over 2 days, actually seems to slow down recovery. Gentle movement is really what you need.
Okay, keep moving. But what about preventing this in the first place or stopping it coming back? Are there things we can change? Risk factors.
Absolutely. Lifestyle plays a big part. Smoking is a known risk factor. It affects blood flow to the discs.
Right.
Obesity puts extra load on the spine. And then there are occupational things, jobs with lots of heavy lifting, prolonged standing, or frequent bending.
So managing weight, maybe quitting smoking, those are preventative. What about fixing the underlying mechanics?
That's where movement and strengthening come in. Activities like walking or cycling have actually been shown to reduce the risk.
Interesting.
And if you do get injured, the goal of movement therapy is to strengthen the core muscles, the back, the abs, the obliques to support the spine better, improve posture, and teach you safer ways to move and lift.
Let's get specific on that movement therapy. What are we actually talking about? Core stability seems key.
It's fundamental, and not just, endless crunches. We're talking about deep muscle control. A really basic but crucial one is the pelvic tilt.
Okay, describe that.
You're lying on your back, knees bent, feet flat, and you gently tighten your lower abs to flatten the small of your back against the floor. Hold it for maybe 10 seconds.
Sounds subtle.
It is, but it teaches that core engagement. You do maybe 8 or 10 reps. That's your foundation for stability.
And then you build on that.
Exactly. Then you might progress to bridging, lifting your hips off the floor while keeping that core tight. Hold for 5-10 seconds, maybe aim for 10 reps, build up to 20.
Okay.
Or the hook lying march. You hold that pelvic tilt, then slowly lift one foot just a few inches, like you're marching very gently, then the other. Keeps the pelvis stable while the legs move. March for maybe 30 seconds, do 2 or 3 sets.
And slight ab curls too, like the abdominal curl up.
Yeah, a small lift of the head and shoulders, hold just 2-4 seconds, focusing on the upper abs. 2 sets of 10, maybe? It's all about controlled strengthening.
Got it. So that's stability. What about flexibility and the nerve itself? If it's pinched, don't we need to stretch things out?
Yes, but carefully. We target common tight spots. Hamstring stretches are important, maybe using a towel, keeping the knees straight. Hold for 30 seconds, couple of reps each side.
Helps take tension off the nerve path.
Exactly. And the piriformis stretch. That deep buttock muscle can sometimes irritate the sciatic nerve. The figure 4 stretch is common. Or pulling one knee across towards the opposite shoulder, the modified 3 stretch. Hold 20 seconds, 3 repeats. Feel it in the buttock.
What about stretching the nerve directly? Nerve glides. Sounds a bit intense.
It's not about aggressive stretching, it's about mobility. The sciatic nerve glide, often done lying down. You hold behind your knee, straighten the knee gently until you feel a slight pull, then gently flex and point your ankle back and forth.
Ah, so you're moving the nerve within its sheath.
Precisely. Just coaxing it to slide freely. Reduces irritation. Maybe 2 sets of 10, holding the ankle movement for 3 seconds or so.
Okay, that's a pretty detailed picture. Stability, flexibility, nerve mobility, those seem to be the pillars for exercise.
They are. But remember, these need proper technique. What we're highlighting are the principles behind effective exercise for this.
Right. So that's the long game. But let's be honest, when you're in severe pain, you want relief now. What about medications?
Yeah, that's usually the first port of call, but the evidence, well, it's often a bit disappointing for sciatica.
How so? What about standard painkillers like NSAIDs, ibuprofen, naproxen?
They might offer some short-term relief, maybe up to 3 weeks, but the overall benefit is considered uncertain, and you have to weigh the risks. Stomach issues, headaches are more common than with placebo.
What about corticosteroids, like prednisone pills?
Similar story. Uncertain benefits, mostly short-term, if any.
Okay. What about the nerve pain-specific drugs, like gabapentin or pregabalin? They're often prescribed for this kind of radiating pain.
They're alternatives. But again, the evidence specifically for sciatica, for lumbosacral radiculopathy, is surprisingly limited. They don't seem to be the magic bullet many hope for.
So pills are looking pretty iffy overall for solving the problem.
For providing significant, lasting relief. Yeah, the data suggests they're not very effective for most people.
All right, if pills aren't great, let's look at other non-surgical things. Hands-on treatments, injections. There was a randomized trial comparing interventions for LSS, lumbar spinal stenosis. That seems relevant.
Yes, very relevant. Even though LSS is often degenerative, the study gives us good comparative data on non-surgical approaches for chronic nerve root symptoms.
What did they compare?
They had 3 groups over 6 weeks. One got standard medical care advice, maybe meds, maybe injections. Another got group exercise classes. And the third got manual therapy combined with individualized exercise.
Delivered by a PT or a chiropractor.
Exactly. Hands-on spinal mobilization, specific stretches, strength training, tailored to the individual.
Okay, 3 distinct approaches. What happened in the short term? Say, at the 2-month mark.
The manual therapy individualized exercise group came out ahead. They reported the biggest improvement in their symptoms and physical function scores.
Noticeably better.
Yeah, and significantly more of them, about 65%, showed meaningful improvement in their walking ability compared to the other groups. So that hands-on, tailored approach seemed to provide a faster initial boost.
But there's always a trade-off, isn't there? Any downsides? Adverse effects?
Good point. The manual therapy group reported quite a bit of temporary soreness. Over half had muscle soreness, nearly half had joint soreness. Basically, the side effects of being worked on quite intensively.
Okay, so you might feel better faster, but you might feel beat up getting there. What about the other groups?
The medical care group had more complaints like stomach upset or drowsiness, likely from the medications or maybe injections they received.
Interesting. So it's a choice between potentially local temporary soreness from therapy versus potentially systemic side effects from meds or shots.
That's a fair way to summarize the short-term trade-off.
Let's talk specifically about those shots. Epidural steroid injections, ESI. They're very common. How do they stack up on their own? Another analysis looked at this, right?
Yes, a meta-analysis directly compared ESI against other conservative treatments for this type of radiating leg pain.
And the verdict, do they work?
They do. For a while, the analysis showed ESI was definitely better than other conservative treatments at reducing pain in the short term, like up to 1 month, and even the intermediate terms, say 1 to 3 months.
So people felt better.
Yeah, patients were more likely to report it as a successful event in those initial months.
But I sense a but coming.
There's always a but. The big caveat is this pain relief did not last. When they looked out to 6 months or a year, the effect was gone. And just as importantly, there was no significant difference in actual functional improvement, how well people could physically manage between the ESI group and the conservative group in the long run.
So it's like a temporary pain mask, but doesn't fix the underlying functional problem long term.
That seems to be what the evidence points to. Powerful for short-term pain, not a long-term functional solution.
Okay, so putting it together. Manual therapy gives a short-term boost in function and symptoms. Injections give a short-term boost in pain relief. But what happens down the road? Let's go back to that LSS study at the 6-month mark.
This is really the key finding, I think. At 6 months, all three groups, the medical care, the group exercise, and the manual therapy individualized exercise groups, showed significant, meaningful, and sustained improvements in their walking ability.
All of them improved significantly.
Yes, their objective walking distance increased substantially, somewhere between 42% and 67% from where they started, across all groups.
So despite the different paths and different short-term effects.
The long-term functional outcomes basically converged. Everyone got substantially better in terms of what they could physically do.
That really underscores the idea that consistency and time are maybe the most important factors for long-term function.
It strongly suggests that, yes.
Okay. But let's face it, some people have pain that just won't quit or serious neurological issues. When does surgery become unavoidable or at least strongly recommended?
There are definite red flags that mean surgery is needed urgently. The main one is cauda equina syndrome. That's loss of bowel bladder control, saddle anesthesia. That's an emergency requiring immediate discectomy.
Okay, that's the emergency scenario.
Also, if someone has severe and rapidly worsening muscle weakness or neurological deficits, that also needs prompt surgical evaluation.
But for most people considering surgery, it's more elective, right?
Yeah.
Because the pain is just unbearable or persistent.
Exactly. Elective surgery, usually a microdiscectomy for a herniated disc, is typically considered when a good course of conservative treatment, say 6 to 12 weeks, has clearly failed to provide adequate relief.
So you've tried the therapy, maybe injections, stayed active, but the sciatica is still severe. Maybe you still have that positive straight leg raise test.
Right. Or the pain just remains unmanageable despite trying conservative options diligently.
If someone does opt for elective surgery, what's the main scientifically proven advantage over sticking with conservative care longer?
Speed. It really comes down to speed of relief.
How much faster?
The studies show surgery gets people feeling better significantly faster. The median recovery time with surgery might be around 4 weeks.
Versus
Sticking with prolonged conservative care, where the median recovery time might be closer to 12 weeks.
Okay, that's a big difference. 4 weeks versus 12 weeks of potentially severe pain and limitation. That's 2 extra months of suffering potentially avoided.
It is, and that difference in quality of life during that period is absolutely significant for the person experiencing it. That's the primary benefit surgery offers.
But how does that weigh against the risks of surgery and the long-term picture?
That's the crucial balance. Surgery clearly offers faster relief, no doubt about it, but
Okay.
and this is consistent across many studies when you follow patients out for 1 or 2 years.
The outcomes equalize.
The overall functional outcomes, how well people are doing in their daily lives, tend to be equivalent between those who had surgery and those who recovered with continued conservative management.
So surgery buys you speed, maybe gets you back to life faster initially, but doesn't necessarily lead to a better final destination a year or 2 later compared to sticking with non-surgical care.
That's a very accurate summary of the current evidence. You trade the risks and recovery of surgery for faster initial relief, but the long-term functional endpoint often looks similar.
Okay, so let's try to synthesize this for you, the listener. What's the big takeaway message from this deep dive?
I think the main message is optimism, actually. Most sciatica is self-limiting. The body has a strong capacity to heal this.
And the prognosis is generally good.
Overwhelmingly positive, yes. Interventions like focused manual therapy, maybe injections, and certainly surgery can speed up recovery or reduce pain faster in the short term. They offer temporary advantages. But ultimately, consistent movement, adopting the right exercises, maybe making some lifestyle changes, and giving it time, those seem to be the fundamental drivers of long-term functional recovery for the vast majority of people.
Which brings us back to something fascinating you mentioned from that LSS study, the discrepancy between self-reported symptoms and objective function.
Right. It was striking. Patients' scores on the symptom questionnaires only showed modest improvement over time.
How they felt.
Yes. But when they objectively measured how far these same patients could actually walk in a timed test,
Their walking distance.
their walking distance improved dramatically. Huge, clinically significant gains in objective function.
So there's a disconnect there. How they felt didn't fully capture how much better they could actually function.
Exactly.
And that leaves us with a provocative thought for you to consider. Why might that be? Why might an objective measure, like how far someone with LSS can walk, be a more powerful indicator of real-world recovery than just asking them how bad their symptoms feel on a questionnaire?
It suggests maybe our functional ability can improve even if our perception of pain or symptoms lags behind a bit.
or that sometimes what we can do changes more significantly than how we feel about it immediately. Something to think about. What truly defines recovery? Is it just a pain score, or is it regaining function?
A really interesting question.
Indeed. Thank you for joining us for the deep dive.